I'm Dan Sale, CEO for St. Louis Realtors, and it's a pleasure to have you here today. I'm excited about this new health insurance affinity program that we've established on your behalf. We know that as entrepreneurs, you have control over a lot of things. Your work schedule, your marketing budget, a lot of things that an entrepreneur has control over. Unfortunately, health insurance oftentimes isn't one of them. And we're hopeful that our relationship with JKB Consulting will change that for many of you anyway. And here with us today, we have two individuals that are going to present. Dr. John Bangs, principal with JKB Consulting. And immediately following him, we'll have Colton Rector here with us, who's going to talk about Medicare benefits. Just quickly, by a show of hands, is there anyone here specifically to learn more about the Medicare benefits? Okay, good. With that, Dr. Bangs, the floor is yours. Thank you.
All right. Well, I have a padded floor, so that's exciting. My name is John Bangs. I was professor of risk and insurance at the University of Missouri for 30 years and also a consultant. I've been a consultant to the city of St. Louis's self-funded health plan and formed JKB Consulting Group some years ago to help develop and manage benefit programs for clients. So JKB Consulting Group is kind of an aggregator, architect, and customized designer for health and benefit and wellness plans. And then we curate those plans for our client base. I was sent off this morning with a little bit of a kind of an unknown challenge. So my girlfriend is a realtor here in St. Louis, but she moved to Colorado. She's a realtor in Colorado. Well, our kids are still finishing school. And so I said, I talked to her this morning, you know, Tara, can you believe in your wildest dreams that I am going to be talking to your realtor association this morning? And she says, smiles and says, John, you're not in my wildest dreams. So that's my launch this morning. How does it make it work? This one. Technology. Glad I figured that out for myself. So we are partnering with brokers and businesses to deliver our product line and our services. We build our own, architect some of our own plans. For instance, we have a lab capitated plan and an RX capitated plan. So for group side of things, we do a lot of work in groups. For $6.95 a month, our client base can get 2,400 labs for no cost, no deductibles, no co-insurance, and that just costs $6.95 a month for that capability. And then we have another plan that covers 1,200 generic drugs for no deductibles or co-insurance at no price, no cost to the employee or employer. So where are we? There's been a lot of indication that maybe our current health system is broken. I don't know about the medical care itself. I mean, those are some pretty good physicians and some of the new developments that are going on, but the delivery of and the cost of and the coordination of healthcare is broken. There's so many variables and so many pieces in the mix that it's really difficult to deliver a good benefit package as well as the ability to navigate that system. Most benefit plans don't really have what I would be considering on what we call our care navigator. So the big ticket item is if you leave a hospital, there's virtually no communication or coordination between the hospital and then going out on your own. That's management of drugs or therapies or durable medical equipment. You're kind of on your own in this kind of haze of access. So that's kind of what we are looking at. How do we develop a care coordination platform? How do we create a plan that's efficient and cost effective. So one of the things that we had a challenge with is when I was at the university, I had the university health insurance, which allowed me to go to the university hospital system, which I didn't prefer. I preferred the independent provider network, but that wasn't an option. So we had a challenge with the network. Fortunately, I didn't have to use it, but I had an annual physical. And I was mentioning before, what happens when you have a big ticket item and how do you deal with that? Last year, about a year and a half ago, I was just fine. Everything was peachy, and I just had lunch with a friend of mine who was a urologist, and I talked to him about a couple things that, I have a couple of things that, I'd like to ask you about. Fine. And he said, well, when was your last PSA test? Well, 12, 13 years ago. He said, come in and check it out. So I went in. The average, if you are, as a male, if you have a PSA of less than 1, you should be okay. Mine was 16. So I was out of the range. And that developed a series of biopsy tests and finally radiation for 5 months, every single day for 5 weekdays for 5 months. And at the end of the year, last year, we were around about $187,000 just from having lunch to $187,000. So it's real. So if you don't have health insurance, it doesn't take long to develop a cost that is staggering and unacceptable. So those are the kind of things that motivated me to come up with something. After I retired from the university, setting up my own business, I was on my own for health insurance until I became eligible for Medicare. And then, so how do we deal with this? How do we make something? How do we create something? And so what we did is we went to the market to find somebody willing to underwrite and manage a sole proprietor, single 1099 platform for us. And that's what most of you are in the gig economy is at. That's a huge economy. And so what happens? What are your options? Your options are you could go to the Affordable Care Act. Okay, if you are eligible for it, ACA is healthcare.gov. So if you're eligible for the ACA, you can get the coverage. It's whatever it is. We're a little better off here in Missouri than a lot of states. There are a number of states that have one company that services the entire platform. Usually high deductible, high copay. It's not unusual to find a $7,500 out of pocket to the ACA, so that kind of makes it untenable anyway. So even if you're getting a premium subsidy, it doesn't even come up to that amount. You could be on your spouse's plan, or if you're under 26, you could be on your parents' plan, or maybe military. Pretty much it. So how do we develop a plan that is cost-effective, manageable, coordinated, and provides a number of benefit options for realtors and sole proprietors? So if you're a sole proprietor, 1099 worker, you are eligible for our plan. We have several platforms that we have available. Some of the issues that we had to deal with is, as an individual, you really don't have group purchasing power. If I'm going to bring a union of, or a group of 2,000 or 3,000 people, I have a little bit of clout with my providers to do something. If not, I'm kind of at the mercy of the plan itself. There are a lot of risk pool disparities. We've got to cover the risk in whatever that platform is that you build. And obviously, the more bodies you have in that platform, the more risk averse that platform can become. So that's an issue. Regulatory challenges. It's just every time we turn around, there are regulatory issues. The state of Montana requires every policy, regardless of what it is, individual or group, to be issued in a unisex rate. In California, they change rules and regulations pretty much daily. It's out there. But they have rules that you cannot exclude anything in mental health, drug, alcohol, whether it's legal or illegal. You have to cover everything 100% for that. There's certain plans that they don't accept out there. And then fragmented marketplace is pretty much out there. So you have all kinds of vendors. My daughter's a nurse, and she worked for Columbia Orthopedic Group in Columbia. And they had 52 different Blue Cross Blue Shield health plans none of them covered the same thing. So having a big name or something, you think, oh, we take Blue Cross, that's fine. Well, yeah, but we don't take that. So those are some of the issues that how do we assure that if you have a provider that's really important to you, how do we make it so that that is an opportunity for you to have that same provider? And then limited government support is 1099 gig economy is not a preferred option of our government. They're trying to remove the gig economy to make them employees so that they can have those work comp and employer benefits and all that kind of thing. So everything is stacked kind of against us as sole providers. So what we've developed is a level funded plan that basically uses reference-based pricing. So what is that? Well, level funded is a subset of self-funded. A self-funded plan is where you as the employer, so this is important, that I'll discuss that later, but you as an employer go and contract with some vendors to provide your employee base with a health plan. The employee pays the first X dollars, the deductible or copay, and that's their obligation. And then you as the employer pay the next level. So let's say that as an employee, I have a $5,000 deductible. So it's my problem, the first 5,000. From 5,000 to some X point is the employer's problem. And after that X point, that employer would retain a stop loss reinsurance carrier to pick up that aggregate body count or that aggregate claims after that point. So there's, and other than that, you don't use that claim pool, then that can be allocated toward future rate increases and other benefits that you aren't needing to fund later on. That level funded, yes, sir.
Can we ask questions while you're doing this?
Sure.
Would you like, can you share those slides with us later?
Yes.
Afterwards, great.
Yeah.
Great. I'm having a little trouble hearing you. It could be me though, but I want to make sure everybody in the room is able to hear you also. I have bad hearing, so it could be me, but I want to make sure. You're having trouble hearing?
No, I can hear you, but I also had a question.
Okay,
Sure.
great.
What you're offering is, are you saying that we are now part of a group who can purchase insurance as realtors?
Correct.
Okay, so we're gonna get a group rate because any realtor that signs up for this plan becomes a preferred member of this group, therefore getting a better deal on insurance.
In a way, that's not exactly like you would understand it from, okay, I'm an association member here and I get a 10% discount. This was specifically designed and built for the realtors in this arena.
That's what I
So
mean.
it's not really a discount, but a specific design, which is really important as we go forward and discuss this. So.
And when you say we, the group, could you define, I was at a loss at who the group really is or who's the we is, what we have done. Is this
Yeah,
only
well,
what's
probably
the affinity group, if you will?
Yeah, I mean, I was referring to JKB Consulting. But the affinity group is the St. Louis Realtor. So if you're a member of the.
Okay, so you have designed this for the St. Louis Realtors, and it's a St. Louis Realtors affinity group, basically. Is that
Correct.
Do I have it right?
Yep.
Okay, thanks a lot. That's
Might be.
Yes.
Okay.
This is being recorded so that everybody could see this in the future, which I didn't know when I walked in, but Don told me that, so it'll be recorded. You all can look at it again.
Apparently that's the case.
Okay, great. And now that you're on mic, it'll be a lot easier. There you go.
Yeah, maybe it is.
Thanks a lot.
If I get this. Okay. Hopefully that works. That work? Okay.
Great.
So anyway, we use level funding as our platform. Then there is an application called reference-based pricing. I don't know if anybody has heard of that, but it is a strategy. So level funding is our platform on which we built this plan for the users. Reference-based pricing is a methodology in which we pay vendors for their service. Reference-based pricing is that as a company, we, JKB, and our vendor partners have set a rate at which we pay providers based on Medicare. So if Medicare paid $1,000 for a particular service, we'd like to pay maybe 150% or 1,500 for that service, for maybe a hospital stay, 130% for physicians. And that's it. So we offer that to anybody. It doesn't matter where you go. You can use whoever you wish to as your provider. And we cover, so there's no network exclusions at all. It is the reference base. So what's the downside? The downside is that if we don't have an agreement with the providers, and we have a lot of those directly, they can balance billing for the balance of what they might. So let's say that I went to BJC and they charged me $2,500. Of course, what they charge at $2,500 might just be fill out paperwork, but nonetheless, $2,500 is what they charge. We might pay $1,500. Medicare would pay them $1,000. So they could technically, under balance billing, charge you that extra $1,000. However, we do the negotiations with them preemptively, and we also wrap the other providers with PHCS network. So really, there's no that balance billing wouldn't ever occur in our network of physicians. It might occur in the hospital system, but anything you go into the hospital for, surgeries or anything but emergency room visit, is going to be pre-certified anyway, and that includes the paying all these bills. And so that becomes a very moot point. Plus, the government came in a couple of years ago and set up the rules that you cannot, if you're a hospital and you have third party like ER people or something like that, you cannot, that separate person cannot bill outside of whatever that hospital is getting. So if the hospital is in network, it doesn't matter whether that provider that's in the hospital is in or out of the network, they've got to be paid at the network. They've got to accept providers, that network provider. So that's how we do that, the reference-based pricing, which is becoming much more popular, and we're seeing it more and more. And the advantage, of course, is that now we have a methodology for you to go to wherever you want. We have found very little pushback by providers if you go preemptively and tell them, here's our new plan, it's got reference-based pricing, set this up, here's our ID card, here's the number, call this number to get any kind of information you want once you're in the system. Really, the only thing we've had is a couple, maybe some new providers that don't know the system, but there's so many different providers out there. It's pretty hard to tell. And you can be in the same hospital, you can be in the same clinic and have providers that are in different networks. So for us, we don't care. You go wherever you wish, and we'll pay. So that's an advantage because you have some, like in Columbia, we have all of the private practice physicians. I was able to get into one organization, one tax ID, one billing structure. So it's a true town and gown at the university hospital system and our private practice. Our private practice is contracted with us for a reference-based pricing. So we pay them 150% for hospitals, 130% for physicians. No arguments, no problems. We pay them within a week. No clawbacks. They love it because they get cash like that. They don't have to fight us. The university, they're just so much more expensive and a little bit confused. Anyway, so we have that capability that we are starting to set up around the country. So they also are providers in the private sector, guaranteed things will not balance bills. So, and that's a preferred option. Everybody wins on that one. The Moberly Hospital was billing at 700% of Medicare rates, and when we came in and offered 150, they just laughed and kicked us out. So we actually pulled all of their patients to Columbia, and they came back and said, "Okay, let's talk about this again. So we'd like to play with you guys. So we've now got in that system in Columbia. So 750 physicians and 5 hospitals. Just
Who was that affinity group for? That was a different affinity group, right?
that's just for Columbia, Mid-Missouri. Columbia.
Was that for the realtors or?
It was for our system. So in Columbia, for instance, if you go to Columbia, you can have that network of private practice.
And who is
Not
the,
quite sure
who is the affinity group?
Well, that's our client base. We don't have an affinity group for that. It's just our network access.
Your
So
client.
that's one of the clients. That's one of the assets that you pick in a level funded health. So you're out there. The foundation of this health plan is level funded. Within that platform, you're going to pick a network or two. You're going to pick a stop loss carrier and a reinsurance carrier and a third party administrator to do all of the processing and claims payments and everything. And then we build that considering the affinity group that we're working with.
I think
It's
Can I just ask a general question so that I can follow along with you? So like, let's say I don't have Medicare. So in your situation, you said $2,500 for the charge. Like, let's say I go in, I get an x-ray. I get a charge of $2,500. They're gonna, the system, and so like, is that including the deductible? Is there a deductible with the plan? So I know how, I'm just thinking like out of pocket charges, how does that work?
you can, when you go into, we have a link that you go into either with a broker or not. And that link will take you to our platform of benefits. And you can pick the deductibles and co-pays and things you want within that plan. We have 10, what you would call metal plans
Okay.
with 3 HSA options. So you can see what you want, what they cost, and how to get to it. Or we have an indemnity plan, which seems to be the most popular of realtors. And that's where our most popular plan actually is a 500,000 capped indemnity. And that means it pays pretty much everything, no deductibles, no co-insurance, just some co-pays in there, and it pays everything that a regular health plan or the ACA plans would pay up until you've hit $500,000. And then you're done. So if you think you're going to have $500,000 in bills, that's not the plan. However, less than 1% of the population in the U.S. hits $500,000. Even with my cancer, it's only 187, but 187. So, but as I mentioned before, I would talk about the fact that you, as a realtor, are both the 1099 employer and the 1099 member. As the employer hat, I can say, all right, you employee, I am terminating my group plan on such and such a date. That, because it's separate and because that plan was terminated, that triggers a compliant compliant platform to go to the ACA. So at that point, I can go to the ACA without pre-existing conditions or anything, and they'll pick up whatever. I may pay more for that plan because it's the ACA, but at least I have an option. You can't do that outside of this plan where you are both the employer separately and the employee, well, yeah, the member of that LLC or whatever you decide to put your system under. So that's one huge benefit, and that's, I think, why a lot of people like that benefit is I can control that. The only time I've seen that kind of claim that's hit over $500,000 is premature birth. Premature triplets has hit over that, but the members knew that way beforehand because they already had the diagnosis and things like that, so they took back to the ACA. So,
And how does it apply, like you mentioned Moberly was different than Columbia, how would this apply if we like went to Florida for a vacation and I broke my leg? Does this different kind of plan, is it hard to do out of state?
no.
Okay.
We're in all 50 states. It operates the same there as here, maybe different members. But if they're, doesn't matter whether they're in our network or not. Or whether they,
Okay.
if they're, you would get the ability to see physicians wherever you are if they have PHCS, but even if they don't, you're under our reference-based pricing, so you can go anywhere. Emergency rooms are covered anyway, because that's kind of required. So if you have the emergency room, you're gonna have coverage anyway, wherever you go. And in this country, the hospital, any hospital that accepts Medicare, which is pretty much everybody, they have to accept, stabilize, and triage you, regardless of whether you can pay or not. So that's, but yeah, we'll cover anywhere in the country. And we will cover overseas some, but you would have to get the bill in English and US dollars and send it in.
Okay.
They'll pick it up from that.
What is the network here, the preferred network?
Well, it's reference-based pricing, but the preferred network is PHCS.
Is that like Mercy and BJC or?
It's a multi-plan. At this stage, we're not sure where BJC sits. Because, you know, they were managing Columbus Hospital. They came here and they weren't part of the normal system. And then they went and picked up that corridor between here and Kansas City. So, of course, it would be covered on the records side, but whether it's PHCS. And you would have, when you go in through the site, there's a link that you can go to see who's in the network today. So networks change, sometimes not very often, but every once in a while there'll be a change in who is a member of that network. So our level funded health plans are generally those for those who are reasonably healthy, because we have 11 medical questions we ask. They're pretty, you know, I'd say pretty benign. I mean, like, do you have cancer? Do you have heart disease? Are you currently pregnant? Something pretty standard. And then, if you don't qualify for a subsidy, we hope that most realtors don't qualify for subsidies. But if you do, then it's kind of hard to beat the Affordable Care Act because it costs you nothing. When my daughter was in nursing school, she was paying $25 a month for a $500 deductible HCA plan. Okay. Of course, that didn't materialize afterwards, but so we asked the 11 questions. If you can answer no to all of those 11 questions, you're automatically on the plan. It doesn't go through any other underwriting. You are effective for the plan you picked the first of the month following that application, and that's it. If you answer yes to any of the questions, you're out of those two plans, and then we have to look at some of the other assets that we have, like short-term and some of these other plans that will take without the medical questions. Even with a subsidy, as I mentioned before, you still have the deductible and copay with the Affordable Care Act. So even if you're on a spouse's plan and you have a $7,500 deductible, we very well could aggregately come up with less costs, even with our premium, than you would have to pay if you hit those levels. Yes.
Do you annually or every 3 years go through and you have to reapply for the plan?
Nope.
Okay, so once I'm in, I'm in.
Once you're in green.
Okay, so if I was in the plan and got one of these 11 questions, just like suddenly I did have cancer, I still am okay.
Yeah.
Okay.
Move on. That's
Okay.
only on the initial application.
Okay.
Yep. Good
Thank
question. Yeah, actually, we will write up to age 63, but if you're on the plan, it carries you to age 65. So you have to really pick up a Medicare or Medicare Advantage, something like that after 65. It's amazing this cost picture. So if we were to write a plan that covered people above 65, we'd have to cover anybody and everybody above 65. And that's one of the highest costs. Was mentioned when I was working with the city of St. Louis here, they had no mechanism for people leaving the plan when they became eligible for Medicare. So people just stayed on their self-funded plan, and it cost them $1,900 a month per person. And this is, 15 years ago, and because nobody thought about it. So that's kind of where most of the plans do fall off. It's a little different with group. If you have a group, and one of the things we do is we have a level funded group plan. We can take 2 employees, and obviously, as long as those 2 are not husband and wife, we can take a 2-person group where if you have, like, say, you're the sole proprietor in your practice, but you have 2 employees, you have receptionist and secretary or something, we can write a small group that has similar coverage, which is an advantage, yes.
You mentioned the age 63, so I'm 63 now, so I won't qualify for this
You
plan
get it through age 63,
through 63.
and then once you have it, it's covered until age 60.
Okay.
And did you fix that plan for the city? They no longer are doing that?
Correct.
Good, glad to hear that.
Well, I'm gonna answer that in 2. One is they're no longer doing that. But we certainly, pretty much impossible to fix the city's plan.
That's
think
that's good.
Half the time, just there to keep people out of jail. They have, what they do is they're looking at their pocket, they're self-funded, they kind of do what they want to do. And they have an interesting population, you know, so it's not unusual to see what would be in a normal environment ineligible dependents, but in this environment, those dependents are literally functionally dependents. You may have a daughter and her baby, and so you as the employee would cover both of them, which is insurance, but it's fine. There's nothing wrong with that, and it's functionally great, and it's a good asset for cyclists to do. Just we have to make sure that the underlying documentation is there to cover. So again, underwriting, normally when you go through underwriting on a health plan, you have to fill out an application, it goes to the underwriting department, they look at it, they do some research on some of the companies that offer these services that will track all your pharmacy and medical claims, and then it takes a couple of weeks to get through underwriting, and then they'll come back with a rate for the group, and it's kind of a labored process, but that's kind of the way it goes. Here, we're asking a lot of questions, that's it. The other advantage of that is we have had virtually no rate increases, at least over the last 3 years, because we ask that up front and we manage those claims pretty well. And we have some resources for service. So if you're going to come up, for instance, our system will come up with a trigger in our TPA, third party administrator, that says if you go to one of these 1099R hospitals, which are any of the not-for-profit hospitals, they have a requirement to cover certain financial obligations that they have under that tax status. So we had a hospital in Kirksville that was a not-for-profit hospital on the 1099R. It's triggered in our system. It came up, the TPA reached out and said, we need to find this. This hospital has this program. We went and found the documentation that they had, filled out the documentation, the employee qualified based on income and everything. The bill went from $287,000 to I think it was $12,000 because of this particular. So there are all kinds of things you could do, but they just aren't there unless you're focused. So if we're looking at how do we maximize the benefit to the population, you guys, and the cost containment, we do a lot of these kind of things that are in our system. So, so our pool, because we have a very good pool, we have not had to have a rate increase. The only increases we have are really demographic. So if you have an aging population, you're going to have a little bit rate increases you get. That's 5-year payments. But other than that, our claim history is pretty stable. And it's a little bit complicated. That was the other reason we had a problem in buildings, or a challenge. But all the legislation and just politics of it, you know, politics, poly meaning many, ticks being blood-sucking parasites, so that was who we were dealing with. And we had the issue where if you have a plan, it's not compliant to aggregate that risk into one pool. You have to separate each individual entity under that pool. Once you do that, then you can aggregate the risk profile across that, and then you have to find a stop loss carrier willing to carry that, which we did. So what we do is we look at each, and in your case, each individual has their risk, but you don't pay the price of being a bad risk in that pool. That whole pool will take on that whole risk and extrapolate it across the entire platform, and it might increase. But so far, we've had enough bodies in our pool that we have not had that issue happen. As we get more and more people, we have less of a chance of that happening. If we aggregated that pool and didn't do this individual, then we would be triggering what's called a MIWA, Multiple Employer Welfare Association for us, and we would become an insurance company and then be obligated about all the laws of the states and all that. So we have to be a little careful on how, and that was part of the building of this plan. How do we get you guys the providers you want? How do we make sure that you can get these flexibility and benefits? And how do we make it cost effective, not only today, but across many, many years? So we have 10 metal plan options and 3 HSA options. They're true ACA plans, don't have the caps in the limits. They're true metal plans, and it's called metal because that's what the ACA calls them. So bronze, silver, gold plans. We also have 3 max options that I kind of explained a little bit earlier. $500,000 cap is our most popular. I would say probably easily 60% of our realtors are opting for that plan, just because it covers a lot more until you hit that $500,000. And then if you do, you're probably in pretty bad shape anyway, and then you could flip over to the ACA anyway. So that makes it pretty popular. Quality of care. Richard's benefits equal or better than what you usually have for large groups, because this is built specifically for the sole proprietor. This is, now we don't have to offer everybody in the plan. So we don't, if you want $500 deductible, you want 1,000, you want 1,500, we got these 10 plans. We don't have to have a standard within all of our plans, but we do with the regular group. You know, you just can't really pick everybody out of different deductible co-insurance. So this is, you can pick that here. Pricing, so far our premiums are somewhere between $200 and $300 better than most groups, offering very similar plans. And that's where it might be advantageous if you're on the spouse's group plan to look at this, considering, okay, I'm not getting a subsidy, or maybe I'm getting a smaller subsidy. Is that subsidy value and my overall risk more than this plan with a less risk, you know, the lower deductible? And we're finding that quite a bit. You know, a lot of these plans, as I said before, if you've got one ACA compliant plan in the state, and it has a $7,500 deductible and co-insurance, so you get up to $10,000 maximum out of pocket. I guess you get $7,500 maximum out of pocket before you even have any co-pay. So this becomes a little bit better plan. This is what's kind of a typical silver plan we looked at. That we have some people with reference-based pricing on this. Silver plan has a $3,500 deductible, $77,000 for family. Maximum out of pocket of $73,000, $14,000 out of pocket for family. Office visit copays, urgent care deductibles, telemedicine. Most everything out there has telemedicine. I'll talk about that. And then our 500 max plan that I was just discussing, it's got no deductible at all, no co-insurance, $500,000 per person, $2.5 million per person lifetime. Office has $50 copay for anything, urgent care, office visits, specialists, $10. ER visit copay is $150, and telemedicine is no cost. Telemedicine is, as I say, pretty much everybody. Everybody has some form of telemedicine, and that's where you have access to a provider. In most cases, an MD or DO or nurse practitioner who can diagnose and prescribe over the phone. These services have to have a physician licensed or provider licensed in the state in which you are calling from. So we have telemedicine across the country. Every state we've got providers. So if you call 24/7, 365, you call it, you can talk to a physician, and they can diagnose and prescribe either through video conference or phone or email, text, not email. You can access the doctor through email, but any of the media that you can access somebody by technology is available, and they can prescribe and diagnose over the phone. We have pretty good luck with that, and we prefer people to use that as the first step rather than go to a physician. It's a lot easier than trying to make an appointment with a primary care doc just to get something for your flu or your sinus infection. And this is pretty popular, so we've got pretty good utilization of this. It also has mental health coverage. We're expanding the mental health because it's just really needed out there, and it's not really very well supported in any of it. We've got wellness plans. We've got health coaching. So if you weight, diet, nutrition, those can all be secured through this, and you can do a couple of ways. You can just do a phone call or access and pick, and you will be linked to the next physician in line, and they can answer. Or you can pick a physician that you want to have talk to you all the time, especially in mental health, and you schedule with that provider for your care. So you'll always be talking to the same person. All our systems take extemporaneous notes. They can forward those to you and your primary care physician, however you want that sent out. And also televet. We have televeterinary medicine, which is very popular. It seems like sometimes people take care of the animals more than their family. Yes.
You've got the example of the premium for the annual max on here. What would a silver sample premium be? What you're showing us?
Good question.
Oh, there you go. Thanks.
These information are not here. Can we have these and print
Yeah.
them?
This will be available for you as well as it's recorded.
After the,
Uh-huh.
okay, thank you.
I have no idea how to do that. She does, so we're in good shape.
Thank you.
And these are some of the representative plan premiums that's in there. We also have a personal health dashboard, a PhD. In it, we have various assessments. So you can do a healthcare assessment, a health assessment to figure out where you are with your risks. We have a medical library to do the research. We've got a PAP, a system to deal with getting back on track for wellness and prevention. We can hold medical records. So if you have anything that comes into the telemedicine system and anything that comes into our system are saved in our HIPAA compliant system for later records. So if you're on the road and you have an ER that needs data and you're there, they can, with your access codes, they can access all of the medical records once they're in the system. Health tracker, benefit tools, there's a wall that you can get, supplements or durable medical equipment or items like that available to you. And here's some of the other benefits that you get. We have the PPO plans, the reference-based, the individual, and the annual max plans. Pretty much, your worksite wellness benefits, telemedicine, health assessments, RX integration, pharmacy, benefit manager. I'll talk about pharmacy in a minute. Diabetes management, medical, medically tracing and imaging. We have EAP, Employee Assistance Program, where we can have healthcare, health, and mental health issues. Balance bill. We negotiate the balance bill should you either get one. Wellness and case management, and again, the medical equipment, so you can get all that through this app and through this plan. Pharmacy. Oh, I'm okay. Pharmacy is always an interesting challenge. Right now, we have pretty much everything that's in the system in pharmacy is a biomed or something with around a 60,000 a month figure. So you're just, it's not easy. Plus, we are as a country, say we as a country, in the US, we eat 85% of all the medications produced worldwide in the US. We produce none. We produce some, but at least the subsidy portions of those drugs are still produced in China, India, Australia, and Sweden. So there are 4 countries, of which at least probably 2 or 3 don't like us, and they produce all of our drugs. We have seen a reduction. My brother has bladder cancer. We're trying to figure out why. He and I had cancer in the same year, and our folks lived to the end of their hundreds with no issues, but we had no answer. So, but he was in the middle of chemotherapy, and in the middle, India shut down their plant. I think that was mainly a maintenance issue, and we had no supply of those drugs in the US. So they had to reallocate and redo his chemotherapy in the middle of the treatment. We are now seeing a shortage of antibiotics, and it's just, and then there was the first of the year, China shut down its plant for a month, shut down its distribution of one of the components that made the substance, I don't necessarily want to call it a drug, the substance that's used in identifying the cancer. So when you go through cancer, if you ever have, they'll inject a radioactive isotope into your system, and like for instance, cancer cells really like sugar. So fluoroglucose is a product that uses a nuclear component and glucose, and that those 2 components are then spun in what's called a cyclotron, and that produces this acid that then is injected into a patient and goes through their system so that they can take a PET scan of your body, and everywhere there's a cancer cell operating, it's a flash, so they know exactly where that cancer is in the body. So it has about a half-life of 6 hours, so you can't really store it anywhere. But interesting, Colombia is the next summer will be the only vertically integrated area in the northern hemisphere that is completely vertically integrated for nuclear medicine. So we'll be able to produce we've got the university system and private system of the reactor itself. We've got a cleaning system, which they're building, finishing that up soon, which now they have to be imported from these other countries. And then the cyclotron is in Colombia as well. So
Which Colombia, Missouri?
so it's a pretty cool opportunity for this Midwest area, because again, St. Louis is easily within 6 hours of Columbia. So there's some pretty neat things that are going on. That system will be in our network. That's part of that system is owned by some of our members. So there's a lot of stuff going on in the industry. There's a lot of stuff going on. The pharmacy we have, again, some of these drugs, the generic drugs are basically free, no deductible co-insurance, or we have all kinds of resources to accommodate the cost of that. And most every company have coupons and discounts, and if you go into a pharmacy and have a prescription, let's say you have a prescription of a Vectrin or something of a higher dollar antibiotic, and it might be $120 for a therapy unit of it. And you say, no, I don't have insurance, I'm just paying cash. Oh, well, that'll be $20. So if you want to make sure that you have the most efficient cost picture for a drug, you tell them you have no insurance and you're paying cash. Unless, of course, your copay is nothing. But it's almost always that cash price at a pharmacy is always less than the actual drug cost. It may not be where you pay everything of that because you put your employer. And if you're both the employer and employee, you're gonna pay for that one side or the other, so you might as well get it as cheap as possible. So cash price is usually pretty inexpensive for that. But for the high dollar drugs, we can source them through Canada. We can source them through Australia. So we have the ability to get some of these high dollar cost drugs. It's a little bit of time involved in that and some paperwork, but basically we have capacity to do that too. So that's helpful. You know, at any given point in time, so we have all this is being offered. We can do it direct. We can do it through brokers. We have several brokers in around the St. Louis area that are more than anxious to talk to you. They can do a one-on-one. They can do it at the agency, however you want to do it. They will be more than happy to walk you through it. It doesn't cost you anything. And what they do is they can do some of the communication. They can do counseling. They can do some of the management of the paper if you have a claim issue. Hopefully you won't, but if you do, which is pretty typical of the industry, especially on the provider side. That's what they do. We do the surveys, risk management. We design the plans. We do health communications. We do compliance. We do the wellness, the risk plans. We negotiate with the various entities, the third-party administrator and stop-loss carriers. We do medical management, and then the third-party administrator does all of the administration. They can do HRA, flexible spending administration. They manage the pharmacy benefit manager relationship, the disease management. They do reinsurance, data management, network management. So that's how those three we all interact with in that capacity. In any given population, you probably have 10% that are sick, about 30% that are at risk of some sort, and the 60% are well. So of that population of the 10%, you got 3% of the employees that require care that aren't getting it, and then employees that were 7% of those that require episodic care, like diabetes. If you're a well-managed diabetic, you're not much of a cost to the system. If you're not well-managed diabetic, you can be upwards to $100,000 for a hospital stay. So it just kind of depends on how well we manage that. If we have a system, if we have in our system, we have somebody that's been on an antidepressant, and all of a sudden you have a PPT, a proton pump inhibitor, PPI, which is acid reducer, we're probably going to see a high dollar gastrointestinal disease state within 6 months. So get back out to that patient to say, hey, here's some options for you if you want to do this. So that's kind of some of the other things that we can do to help mitigate that risk. So we have pretty much a plan that can fit anybody. We can manage all of those, big or small. We have endemic plans. We have the GET plans. We can do large and small groups. Our focus is on the realtors and this 1099 program, which we think is great. Any of the gig economy out there kind of crying for this. So we hope that that's going to be beneficial for you, and we certainly want to be help you get into these plans if it fits your needs. And anything you have to talk about, call us or one of the brokers that we have here. Yeah. So, any specific questions? Yes.
I'm asking for someone else, but do you offer dependent coverage?
Sure.
Ages that have kids? Okay.
We have a 4-tier system. So it's employee and children, employee and spouse, or family. So you can do any one of those within this platform. Our medical plans, the metal plans are age banded. Our indemnity plan is one standard premium. Yes.
So you had a slide that had silver RVP versus 500 annual max. Can we go back to that when you're done? Can we go back to that?
Sure.
Thank you.
Yeah. Anybody else? Yes.
This is only offered to realtors. in this association? Can it be offered to our clients also, or just the realtors or members of the association?
Right now, this plan is for the members of the association.
Mhm.
If you have a client that is interested, so like say you just sold a house to a guy that has a business. If they come in through our realtor association network provider, then that you can do that, and we would support contribution to the association. So
Say it again, the last part.
if that person that you refer comes through our system, yeah, you can send them our way, and it'll be a plan that they have, but we would support the association for
How do they
having you
come
send
into your plan? If
sign,
they-
just like anybody else. They can go to the link and they can sign
This
up.
is your client can come in through working with you can be qualified? Your client, your buyer or seller,
If they,
just by working with us, they can be qualified to use this?
if they are a 1099 or a sole proprietor, that qualifies them for this plan.
What is 1099 again? I'm sorry,
That's a non-employee pay.
non-employee pay.
So you can be a sole proprietor and have your own LLC or something, or you can be a 1099 employee for somebody else. It's just not a W-2 relationship. Therefore, you don't get benefits. So
So
that's up to you.
I'll follow up with you later. I don't want to go down a rabbit hole, but it could be a great benefit from my perspective of us being able to do this with our clients.
Yeah.
Another service we're adding, but I don't want to get into the weeds here. You know, it's hard enough to understand this, much less
Yeah, it's,
a whole other level of this.
it is.
Right?
So, yeah.
Yeah, but thank you very much. It's really interesting.
I have another question. Every day, literally every day, I get text messages from these people who want to sell insurance to realtors. And yesterday, I got one and I thought, okay, let me respond to this one. And in the beginning, I respond like spam or block, and I keep getting them. I don't know, they get the list, they buy the list of the realtors from somewhere. Anyway, yesterday I told them that, yes, I'm interested. Give me more information. And then she said, can I schedule you to talk to my manager? And I said, no, I don't have time to talk. Just send me your information, the plans, the pricing, because tomorrow I will be in a seminar for medical for realtors. And then I can compare yours with them and make a decision. She stopped talking to me.
Surprise.
So what's the issue? Why are they trying to keep writing to you with this? What's in it for them? Obviously,
Commissions.
there's not much for us.
Well, they're more than likely, in most cases, insurance agencies or brokers
Right.
that, they have a commission that they make by selling a plan of some sort, whatever that plan is.
Okay.
A lot of them sell the ACA
Right.
plan,
What is ACA?
Affordable Care Act. It's Obamacare, basically.
Oh, ACA. Okay. Affordable.
And that set the rules a few years ago as to how the insurance will be delivered into the future.
But you can go to ACA website and start shopping there yourself. Why do you need these third-party brokers?
Well, they hope you don't know that.
Okay, thank you.
And that being said, the ACA or the healthcare.gov is not that easy to get through.
Right.
So,
You
and then you
walk
have to
the-
qualify, and it's kind of a pain. So,
And then your phone will start ringing because you start getting quotes right and left.
oh yeah, it hemorrhages into your phone.
Yeah.
Well, thank you, everybody. Appreciate it.
Dr. Baines, thank you. Perhaps he could wait in the lobby and have one-on-one conversations with any of you that have follow-up questions. Would that be possible? Let's thank Dr. Baines for his time. On our website, stlrealtors.com,